My name is Matthew Khan. I'm a consultant cardiologist and heart failure device lead at Pennine, and I'm here to talk about the primary care heart failure service at Inspire Health. Heart failure is a persistent and progressive disease, and symptoms follow a relapsing and remitting course. And we know that patients with heart failure associated with reduced ejection fraction are at high risk of sudden cardiac death. Heart failure is a huge problem in the UK in terms of prevalence, incidence and cost, and this is a problem that's only going to get worse. The standard of care that we deliver in terms of heart failure is getting better in terms of pharmacotherapy. Our ability to prescribe ACE inhibitors, beta blockers and aldosterone antagonists is getting much better, and also in terms of device therapy. Despite this, mortality rates remain high. 30-day in-hospital mortality rates is around 6%, and that gets worse towards 5 years. Over the past 30 years, our ability to prescribe medications has changed a tremendous amount. 30 years ago, the only evidence-based therapy was enalapril, and that's progressed significantly. So now we have other pharmacotherapies, beta blockers, aldosterone antagonists, other drugs like Entresto and ivabradine, and of course we also have device therapy. When we think about device therapy, we think about biventricular pacemakers, biventricular defibrillators, or implantable defibrillators. These are devices that can potentially make a heart failure population feel better, but can also prevent sudden cardiac death. All the evidence tells us that these devices prolong life, they reduce your chance of being admitted to hospital, they improve symptoms, and they improve the lives of the heart failure population. Guidelines over the past 5 to 10 years have changed significantly, and so there is a significant amount of patients within the community that may be candidates for device therapy that don't have access to this technology at the moment. I've been in post at Pennine now for well over 2 years, and when I first arrived I became aware of a population of patients that were candidates for this technology, but also weren't getting the best heart failure care, and I wanted to find a mechanism to try and reach them. These are patients that may have been discharged from the heart failure service many years ago. These are patients that may have been admitted to hospital recently but weren't referred to the heart failure service. There are even patients that are in the community and feel well, but they're not on optimal medical therapy. Primary care heart failure service, working closely with Inspire Health, gave us a mechanism to try and find this population of patients. And it consists of 5 phases. The first phase uses a tool called GRASP-HF. This is an audit tool that identifies patients with heart failure and left ventricular impairment. The second phase consists of a patient medical record review. It looks at all relevant medical patient details and test results. Phase 3 consists of patient invitations, and the patients are invited to attend a consultation clinic at their local primary care centre. Phase 4 consists of a consultant cardiologist review at the local primary care centre, and Phase 5 consists of follow-up at 6, 9 and 12 months. From the first 10 practices that we performed the primary care heart failure service, 100 patients were identified to be reviewed by a consultant cardiologist. 20% of those patients either had a device implanted or were on the waiting list to have a device implanted. A further 20% of those patients are under active follow-up in the device clinic, and so are potentially waiting for a device. The really interesting part of this project was that around 45% of these patients seen needed medical optimisation, and so were brought into our heart failure service at Pennine. In terms of the benefits of the Inspire Health primary care heart failure audit approach, it ensures patients with heart failure are identified and optimally managed to improve health outcomes and potentially reduce chances of future hospital admissions. It increases the numbers of patients being referred into specialist centres for consideration of advanced pharmacotherapy and device therapy. It makes sure practices are NICE compliant in terms of pharmacotherapy for heart failure and also device therapy. This is a consultant-led service in the community, and patients seem to really enjoy the fact that they're seeing their local consultant cardiologist in their local GP practice. It increases local knowledge of evidence-based therapies for treating heart failure, and for me it's allowed greater engagement between the local heart failure team and primary care, and this is vital for optimising our heart failure population. Around 12 months ago I came across a 57-year-old lady who had had a previous diagnosis of dilated cardiomyopathy. She had an ejection fraction of close to 20%. She was also in atrial fibrillation with a rapid ventricular response. She had been discharged from the heart failure service many years ago and was certainly not optimised. When I saw her, she was extremely unwell. Clinically, she was MYHA4, so she was breathless getting dressed. And it was very apparent to me that not only was she a candidate for device therapy, but certainly she needed optimising, but also she actually needed referral into the local tertiary centre for transplant consideration. We brought her into our service initially and optimised her fairly quickly, even just doing simple things like increasing doses of basic pharmacotherapy improved her significantly. She went on to be referred to the tertiary centre, who were happy with the progress she was making, and she wasn't a candidate for transplant at that point. 4 months after she was first seen in the primary care heart failure service, she was listed for a prime prevention ICD, and that procedure went without problem.